Jumping to the next one that we're kind of currently in the middle of, Mike, you referenced the meeting that came up and had to get thrown together quickly. Unfortunately, and because of that quickness, I wasn't able to get out of clinic to get down there and be a part of it. But that's the talking about the parity language, and I believe that's getting that into our practice act. Yes, okay, I'm getting nods, so I said that correctly. Could we just start off with what is parity language and why does it matter, and why are we looking to reopen our practice act to have that be a part of it?
Well, the parity language is actually not part of our Practice Act. This
Okay.
is an amendment to an existing statute that looks at insurance reimbursement. So
Yep.
it's in a different section of our administrative code. And essentially, several years ago, a group of other health professionals were looking at kind of their reimbursement abilities based on what they were doing clinically. So the three groups that kind of spearheaded that a while ago were the optometrists, chiropractors, and dentists. Right. So whether it was they were looking to expand or whether they were dealing with certain procedures and the cost for that being denied by insurance companies, they basically said, well, if an insurance company is going to reimburse for this service, if that service is provided by a licensed healthcare provider, they can't refuse it because it's a service they already reimburse. And so the argument was that they were kind of picking and choosing which healthcare professionals could provide that service and not
Sure.
leaving it up to the patient or the physician or the decisions that they wanted to make medically, whether it's by convenience, whether it's by patient preference, or whether it's just appropriate for that healthcare professional to provide it. So when we started looking and working with our reimbursement committee, and we were dealing with insurers that were not very willing initially to jump on board to reimburse us for the clinical services that we were providing. So we started looking at how we could go about this. And the first and probably the most important way, as Joe said, was to develop relationships, to educate, to have days and days and days of dialogue and communication, and to kind of sell ourselves and allow what our skill set is, what our training and Joe's remarkable personality when he would meet these people face to face, to convince them that not only is this a good thing for us because it could potentially be economically viable and financially a good idea, but it also is going to be something that's good for our patients. But after a while, some of those negotiations started to fizzle. So then I kind of took it on myself to kind of look again at what other healthcare professionals are doing, and I stumbled across this piece of administrative code. And one of the nice things about that is it's a piece of statute that's kind of a piece of language that's outside our statute. So technically, we're not opening up our Practice Act with that. And it's always easier to amend existing code than it is to create new code. And so that's kind of how this kind of emerged. And Joe, you could probably share a little bit more about some of those early negotiations that went on. So essentially what that piece of language states is that, again, if an insurer reimburses for services that are provided by other healthcare providers, they can't discriminate against a healthcare provider who is licensed and trained to provide that same service. So it's not like we're doing anything different. The insurance companies aren't really doing anything different because they're already reimbursing for those services. It's just
Hmm.
now making sure that we're kind of on a level playing field. And so the goal there is to provide patient choice, to kind of remove barriers to access for those services, and to obviously create opportunities for athletic trainers to be a viable clinical entity. So not having to have those battles and making sure that if they are working in clinic, they're going to be reimbursed for the services that they provide, and removing some of the obstacles to achieving that.
That was perfect. Thank you for that. Like I've now all of a sudden feel like I actually understand why we're going for it that I didn't before. So thank you for that. That was definitely what I was hoping for there. Joe, what do you have to add?
Yeah, I would just say, to provide a little bit of background on where we've been as a state with this is, we've had employers, pursue reimbursement and advocate for their ATs for over 20 years now. since the year after we became licensed. And I think it was in 2010, the WATA went through a strategic planning process, and we basically agreed at that time to say that our goal was to be reimbursed consistently with other providers when we're delivering medically necessary types of care for athletes, for our patients. And so we agreed that we would pursue that by educating insurers at first, and often employers as well, to try and get to that point in time. And so we have been able to secure some 55 insurers in the state of Wisconsin who will say yes to us when we do request reimbursement for the right types of services. A lot of those are work comp payers, some are commercial carriers, some are HMOs. And sometimes we get approved just on prior auth with some companies that don't formally recognize ATs. But in the end, we also agreed that in that pathway is if we had to pursue a legislative solution or a legislative fix to this because we couldn't get to where we wanted to, that we would need to do that. And that's really where we are now. And for me, something that I hope I can be a part of, not only in Wisconsin, but nationally, is that the business decision of an insurance company not to reimburse an athletic trainer for services that they can deliver under their scope, we do it all of the time, affects our ability to work up to our scope of practice in hospital and clinic and independent practice environments. Is many times athletic trainers just can't get hired in those settings for delivering care they deliver in other settings. So it's obviously something that I've been passionate about trying to change, that I want to change for athletic trainers so they don't have to deal with this in the future, is that they can be employed in those types of settings if an employer wants to hire them. But I think that is the goal of this legislation is we hope we could get there from an educational perspective and advocacy perspective, but I don't think we can, and especially with our state's largest payer, United Healthcare. But there are others as well. So that's why we're involved in this process right now.
Just seeing our last kind of e-blast on how things went. What impact would this have for ATs? I think the main one, if I'm summing up right, is basically getting compensated for the same work that we're providing because they're doing it to others. What resistance might we be getting, and who from, and why do you think that is, when from what you both just laid out, it seems to be fairly intuitive that it should go forward and it makes just sense.
Right. Well, obviously the main opponents to this is the state's insurance industry, and Joe can kind of refer to that and their organization, their lobby groups, kind of what their main arguments have been all along. One of the things that comes up that we often have to kind of work around is the term mandate. Insurance companies and businesses don't like being told what to do by the government or by anybody else, right? Just like we want to make our own decisions independently with our patients, they want to make their own decisions as to what's best for their business model, and their bottom line and their shareholders. And I'm sure they have concern for their patients in their insured members somewhere. But that has been part of the issue, is like, well, this is considered an insurance mandate. There has to be, for these types of pieces of legislation, the state budget office has to kind of look at what the potential costs are. And so they'll come up with a number. Again, Joe can probably relate more as to the mechanics of how that occurs, but they'll come up with a number, and then we have to kind of look at those costs over time and then kind of justify those as well. From other healthcare providers, we haven't gotten a whole lot of resistance on this. I'm sure we'll talk about the term vigorous as we wrap up.
That is the next one.
But, the physical therapists, the first time we proposed this to them, they said, wow, good luck. We don't think you'll get it, but okay, go for it. So at least, everybody else seems to have remained neutral. We haven't really had any opposition from physician groups. And, I've approached a couple of our doctors. If it gets to that point, they said, yeah, we could probably put our name to a letter or those types of things. So as Joe will allude to, most of the arguments have obviously come from the insurance industry itself.
Got it.
Yeah, and I think when we did the reimbursement pilot, that was from 2014 to 2017, we really identified like really essentially because weren't a lot of sites across the country that were billing autonomously with ATs. So cost outcomes or, how effective is an athletic trainer delivering the same type of care after an anterior cruciate ligament reconstruction or a rotator cuff repairs is how do they compare to other types of providers? Well, that was a gap in some of our objective data. So I think we're in a better position to be able to secure some of that data. I think that's what insurers want to see, is ultimately are we as cost effective as other types of providers when we deliver the same care to the same age group, for the same pathologies, things like that. I think importantly also, and we do have some pretty good data from the state of Massachusetts, who has proposed similar legislation, is the state tries to estimate, and this is really hard to get your arms wrapped around this. Our Medicaid office in our state has asked for the same thing, is like, what is the additional cost to insurers? What is the additional cost to Medicaid for this? And so the state of Massachusetts, an independent consulting firm, they were required to be able to do an analysis on this. And they're a similar size to Wisconsin as far as the number of licensed athletic trainers, is they took out estimates for 5 years as what it would cost the entire insurance industry in the state of Massachusetts if this type of language was improved there. And the costs were really relatively low, like in the first year, estimating some $800,000 to all insurers in the state of Massachusetts, because not many would start in the first year. There wouldn't be a lot doing it. But by the end of year 5, they estimated those costs to grow to approximately $6 million a year to all insurers. So again, it's hard to predict, but these aren't extraordinary costs to insurers when you look at what other types of services they have to consider paying for. But I think those things are on us. Like Mike said, is the PTs have kind of sat on the sidelines with this issue, but we have to be able to show objectively that we're cost effective providers beyond being safe and effective providers.
And I think that's true of any business, right? If you have a business and you want to try a new initiative or do something, you kind of look at risk versus reward, cause and effect, those types of relationships. And some of this, I think, too, is just a matter of perspective, right? So the insurance company is going to look at it from, are we processing more claims? And of course they are, because there are going to be more people billing for those services. But when you look at it from the perspective of the patient's viewpoint, they're still getting those services regardless. If we can do it more efficiently, if we can get to them sooner, maybe they don't need 24 rehabilitation visits. Maybe we can do it in 8, right? So as Joe said, it's a hard thing to forecast and to estimate, but it's also part of a matter of perspective. And so, insurance companies have been battling government regulation for ages, and they've have lobbyists and governmental affairs people too that are highly skilled. So sometimes we don't know what the argument is going to be going in. We kind of know what their approach is going to be from a yay or nay standpoint, but it's one of the things you kind of learn as we go. And it's where Joe's group with OrthoVise, as far as being an advocate for our profession, has been really, really helpful, because they spearheaded kind of all these conversations. And I think not only Joe and his group, but we've all learned a lot, and we're able to kind of understand their perspective a little bit more effectively because of it.